Concept 20, clotting. All cells depend on a consistent supply of blood. When injury occurs to veins and arteries, the clotting process is initiated to stop the blood loss. This represents an important physiological protective mechanism allowing the body to maintain homeostasis when injury occurs. Excessive clotting can impair perfusion, whereas inadequate clotting increases blood loss. For this reason, clotting is a critical concept for nurses to understand and incorporate into practice. Nurses should identify individuals at risk of impaired clotting, recognize when individuals are experiencing impaired clotting, and respond with appropriate interventions. Learning objectives. Define and describe the concept. Notice risk factors for ineffective clotting, which is bleeding and excessive clotting. Recognize when an individual has compromised clotting. Provide appropriate nursing and collaborative interventions to prevent clotting problems, and manage clotting situations when they occur. For this purpose of the concept presentation, clotting is defined as a physiologic process in which blood is converted from a liquid to a semi-solid gel. This is a normal and expected physiological event that usually starts when arteries or veins are injured. Multiple coagulation factors interact in a sequence with fibrin and platelets to form a blood clot. The result of the clotting process is homeostasis, a term that refers to the stoppage of blood flow or bleeding. The clotting process can become impaired in two ways. First, when the clotting factors are not available, patients experience excessive bleeding. Alternatively, if blood clots form when they are not physiologically indicated, then a thrombus, a blood clot, may obstruct blood vessels and interfere with blood flow. The effects of impaired clotting vary depending on the extent of impairment and the anatomic location. The scope. The concept of clotting and problems associated with impaired clotting represent a variety of physiological processes. The scope of the concept represents a continuum ranging from excessive clotting beyond physiological need at one end of the spectrum to impaired clotting resulting in bleeding at the other end. Expected physiological clotting processes fall in the middle of this continuum. Both excessive clotting and ineffective clotting can occur locally or systemically. Figure 20-1 depicts the continuum of clotting as a concept, which you can see here. The homeostatic process is a protective mechanism to prevent excessive bleeding when vascular injury occurs and is achieved through a complex coagulation process. In a normal clotting process, the damaged vessels, platelets, and clotting factors work together to stop bleeding. The first response is vasoconstriction, which reduces blood flow, allowing the clotting process to start. Bleeding is slowed further when accumulating blood surrounding the blood vessel creates pressure against the walls of the affected vessel. The second response, triggered by the damaged blood vessel, is formation of a platelet plug. Platelets are activated and stick to the injured blood vessel because of a protein called von Willebrand's factor produced by the cells of the vessel wall. The platelet plug develops in 3 to 7 minutes. Next, clotting factors are activated either from the intrinsic or from the extrinsic pathway and proceed in a coagulation cascade to the common final pathway. The difference between intrinsic and extrinsic pathways have to do with the initiation of the clotting factors. The intrinsic pathway is activated by collagen exposure when there is damage to the surface of the blood vessel within the vessel. The extrinsic pathway is initiated when damaged tissues release tissue factor or tissue thromboplastic, which is external to the blood vessel. Both intrinsic and extrinsic pathways converge to follow a common final pathway, whereby thrombin stimulates fibrinogen to form insoluble fibrin that stabilizes the clot. Figure 20-2 illustrates the coagulation cascade. Variations in context. Variations in clotting may occur in individuals across the lifespan with a wide range of impact, and they represent conditions associated with excessive clotting or conditions associated with excessive bleeding. Variations in the normal clotting process occur in relation to the presence of clotting factors, the size of the vessel affected, the type of vessel, artery, or vein, and the location of the bleeding. When there is an excess of clotting factors, thrombi may form. A deficit of clotting factors may produce bleeding. A significant difference results depending on whether the blood vessel is small or large. The pressure of blood is greater in arteries compared with veins. A simple paper cut of a finger can cause immediate bleeding from a vein in a small area of the body, whereas severing a major artery can result in severe blood loss and perhaps death. The location of the bleeding is another variable. For example, bleeding from a weakened artery within the brain can cause immediate neurologic deficits, and perhaps death, whereas bleeding from veins injured by a skinned knee impairs the skin integrity, causes some discomfort, and can be healed perhaps without a scar. Consequences. Pathophysiological consequences of excessive clotting called thrombi. Normal homeostatic processes can become impaired when excessive clotting factors lead to thrombus formation. A thrombus can form in arteries or veins. The impact of one or more multiple thrombi can vary from partial obstruction to complete occlusion of the affected vessels. Arterial thrombosis. Arterial thrombi are associated with conditions that increase platelets or erythrocyte production or create turbulent blood flow with platelet adhesion. Another source of thrombi is atherosclerosis, which begins with injury to the endothelium. Causes of endothelial injury include hypertension from the increased pressure of blood in the arteries, creating a shearing force. Other causes of endothelial injury include exogenous chemical agents such as toxins from cigarette smoke and endogenous agents such as cholesterol. When a thrombus blocks an artery, it interrupts the flow of oxygenated blood to the tissue, leading to ischemia. If left untreated, this results in cell death. However, if adequate collateral circulation exists, it can compensate for the reduced blood flow and avert cell death. The pathologic consequence of such an event is determined by the artery location, such as a coronary artery, a cerebral artery, and a femoral artery, and the size of the thrombus in relation to the size of the affected artery. A large thrombus in a small artery may stop the flow of blood, whereas a small thrombus in a large artery may create turbulent and slow blood flow. A thrombus that detaches from an artery becomes an embolus and can lodge in another artery. For example, a small arterial emboli flowing through a cerebral artery can cause transient ischemia, or a large arterial emboli can lodge in a cerebral artery, creating a cerebrovascular accident, also known as a stroke. Venous thrombosis is the formation of a blood clot in a vein, usually in association with inflammation within the vein. Superficial and deep veins may be affected. 3 factors associated with the formation of venous thrombosis are hypercoagulability of the blood, injury to the vessel wall endothelium, and stasis of blood flow. These 3 factors are commonly known as Virchow's triad. Endothelial damage of the vein initiates the release of clotting factors or activates platelets. Stasis of venous blood occurs when there is dysfunction of venous valves, inactivity of extremity muscles, or change in unidirectional venous blood flow. A thrombus that detaches from a vein becomes an embolus and can lodge in another vein. For example, a thrombus from a deep vein thrombus in the leg can lodge in pulmonary vessels, creating a pulmonary embolus. Pathophysiological consequences of inadequate clotting or bleeding. Bleeding occurs after injury to arteries and veins, but it can also occur spontaneously when the factors needed for clotting are reduced. The clotting factors include platelets and clotting factors 2, which is called prothrombin. Also 2, 7, 8, 9, and 10. So 2, 7, 8, 9, and 10 are the clotting factors for prothrombin. The extent of bleeding can be as minor as bruising or as significant as a hemorrhage. Thrombocytopenia is defined as a platelet count less than 150,000 cubic millimeters, although the decrease is not considered significant unless the platelet count declines below 100,000 per cubic millimeters. When the platelet count declines below 500 or 50,000 millimeters cubed, the risk for hemorrhage after minor trauma increases and petechiae, purpura, or ecchymosis may form. Spontaneous bleeding without trauma, such as a spontaneous nosebleed, occurs when the platelet count ranges from 10,000 to 15,000 millimeters cubed. Liver disease, such as cirrhosis, impairs the liver synthesis of clotting factors, including factors 2, 7, 9, and 10. Reduction in the amounts of these clotting factors prevents formation of clots after trauma or hemorrhage. The impact of hemorrhage on an individual varies with the percentage of blood volume loss. After loss of 20% of blood volume, the person has tachycardia on exertion and slight postural hypotension. With the loss of 30%, the person has tachycardia at rest, postural hypotension, and flat neck veins in a supine position. With the loss of 40%, the manifestations are hypotension, tachypnea, which is rapid respiratory rate, and cold, clammy skin. With the loss of 50% of blood volume, there is hemorrhagic shock and death. Hemolytic anemia can be a consequence of blood loss that affects several body systems. The effects on the respiratory system include increased respiratory rate and dyspnea on exertion. The cardiovascular system responds by increasing the heart rate and peripheral vasoconstriction. The effect on the nervous system is the emergence of confusion, anxiety, dizziness, and fainting. The skin and mucous membranes become pale. The person reports weakness and fatigue. Risk factors. Populations at risk. Older adults have increased risk for clotting because of expected physiological changes that occur with advanced age, such as increased platelet adhesiveness, which promotes blood stasis. Individuals of black race may have a genetic disorder called sickle cell anemia. When affected persons experience hypoxia, dehydration, low temperature, or metabolic acidosis, their red blood cells change to the shape of a sickle, which results in abnormal clotting in peripheral arteries, causing ischemia and pain. Individual risk factors. Impaired clotting affects all individuals regardless of age, gender, race, or socioeconomic status. Common risk factors are described. Genetics. Several genetic disorders are associated with hematologic conditions. The classic example is hemophilia, a recessive genetic disorder caused by the inability to produce adequate clotting factors needed for blood coagulation. Hemophilia A and hemophilia B are similar in that they are both recessive-linked genetic disorders in males whose affected clotting factor is defective or deficient. The difference between these types of hemophilia is the affected clotting factor. In hemophilia A, factor 8, V111, which is the Roman numerals 8, is deficient, whereas in hemophilia B, factor 9, which is 1X, that means 9, is deficient. So A, 8 is deficient, B, 9 is deficient. By contrast, von Willebrand's disease is a bleeding disorder that is an autosomal dominant genetic disorder affecting both genders. Affected individuals have a deficiency in von Willebrand factor coagulation protein and factor 8, as well as platelet dysfunction. Deficiencies of these clotting factors result in spontaneous bleeding, including nosebleeds, and hematuria, which is blood in the urine. Immobility contributes to blood clot formation by slowing the return of venous blood to the heart. Slow blood flow results in stasis, a risk factor for thrombi formation. Immobility may occur as a result of paralysis or an unconscious or impaired cognitive state, or from bed rest needed to recover from an illness, injury, or surgery. Individuals who are confined to a sitting position for long periods, such as long airplane flights, are also susceptible to the formation of venous clots. Smoking is a known risk factor that contributes to hypercoagulability of the blood, a contributing factor to clot formation. Assessment. Nurses gather data from the patient's history, physical assessment, and diagnostic test results. Adequate clotting is apparent when the patient forms a blood clot after endothelial damage. Peripheral pulses are present, capillaries refill within less than 2 seconds, and the skin is warm and dry without discolorations, such as bruises or the presence of edema. Also, blood pressure and heart rate are at expected rates for the patient's age. History. The history includes current and past medical conditions. Nurses inquire about patients' chronic diseases. Many medical conditions are associated with bleeding or clotting disorders. Common conditions associated with clotting disorders are presented later. Also included in the history are medications the patient is currently taking because many medications affect clotting. Aspirin is taken daily by many people to reduce the potential for clot formation. And because of its antiplatelet effects. Warfarin, otherwise known as Coumadin, is a prescription drug taken to prevent blood clotting by interfering with the 4 vitamin K dependent clotting factors 2, 7, 9, and 10. Nurses also ask patients about over-the-counter meds or herbal and dietary supplements they take that may affect clotting. These supplements include bilberry, black cohosh, chamomile, chondroitin sulfate, feverfew, garlic, ginger, ginkgo biloba, ginseng, golden seal, omega-3 fatty acids, melatonin, niacin, soy, and turmeric. Lifestyle behaviors are important to assess as part of the history. Questions include exercise habits, including the kind of exercise and how often it is performed, and for what length of time, because exercise increases blood flow. Nurses ask patients about smoking habits because nicotine causes vasoconstriction and is a toxin that damages the endothelium, contributing to atherosclerosis. Bleeding. The nurse should ask about abnormal bleeding from gums when brushing teeth, from the rectum after defecation, or after a minor trauma. Patients may describe bleeding that takes longer than usual to stop. Patients with bleeding problems may report bleeding in many forms and from various areas of the body, including nosebleeds, new bruises, black tarry stools, blood from the rectum, which is called hematochezia, Hematochezia, blood in the urine, hematuria, blood in emesis, hematemesis, which is spelled Hematmesis, coughing up blood, which is hemoptysis, or bleeding from the mouth. Indications of intracranial bleeding may include a headache, changes in vision, sudden difficulty talking, or weakness of one arm or leg. Patients may report fatigue or dyspnea from anemia caused by blood loss. When applicable, women are asked about the amount of blood lost during menses and whether the length of menses has increased. Parents of children with hemophilia may report that the children bleed after minor trauma, such as from a circumcision, during or loss of deciduous teeth, or after a slight fall. Bleeding into a joint called hemarthrosis may produce complaints of stiffness, tingling, or ache of knees, elbows, and ankles. Hematuria may be reported. Clotting. The nurse asks patients about recent prolonged sitting, such as on an airplane or in a car, or prolonged bed rest, because these are risk factors for venous thrombosis. Nurses should inquire about swelling, redness, and pain in the extremity. They should also ask about a history of atrial fibrillation, which increases risk of atrial emboli into the cerebral circulation. A report of leg pain when walking may indicate arterial insufficiency of the lower extremities. Examination findings. Examination findings. Bleeding. When assessing patients with prolonged bleeding, nurses may notice petechiae, ecchymosis, and purpura during inspection of the skin that indicate localized bleeding in the subcutaneous tissue. For patients with hemophilia, subcutaneous and intramuscular hemorrhages are common. Hemarthrosis, which is the bleeding in the joints, results in warmth, redness, edema, and severe pain of affected joints, followed by decreased joint range of motion. Bleeding into the brain produces varying manifestations of stroke depending on the amount of blood released and the area of the brain affected. When bleeding is excessive, changes to vital signs, specifically increased heart rate and decreased blood pressure, may be noted. Clotting. When assessing patients with a thrombosis, nurses find different manifestations depending on the location and whether arteries or veins are affected. Clots within veins frequently develop in lower extremities where they impair perfusion and cause pain, redness, and edema with an increased circumference of the affected extremity. The patient may have a palpable firm vein that is tender to touch. When venous thrombi become emboli, the emboli flow superiorly in the inferior vena cava and lodge in pulmonary capillaries. Manifestations produced from pulmonary emboli vary by location affected and size of the emboli. However, the classic triad includes dyspnea, which is shortness of breath, chest pain, and hemoptysis, which is blood, coughing up blood. As mentioned previously, an arterial thrombus in the lower extremities impairs perfusion. Accompanying the common reported symptoms of pain and paresthesia or numbness may be other manifestations such as pulselessness, pallor, and poikilothermia, which is cool skin temperature over the affected area. That's spelled Poikilothermia. These are often referred to as the 5 Ps. Blood clots that travel as emboli through the carotid circulation can impair perfusion to the brain, producing manifestations of a brain attack that vary by location affected and the size of the emboli. Diagnostic tests. Prothrombin time. Prothrombin time, called PT, measures the adequacy of the extrinsic system and common pathways in the clotting mechanism, which include clotting factors 1, called fibrinogen, 2, called prothrombin, 5, 7, and 10. When these clotting factors are found in decreased amounts, the PT is prolonged, meaning more time is needed for blood to clot. PT results are reported in seconds along with a control value. The patient's value should be approximately equal to the control. A normal PT finding is 11.0 to 12.5 seconds. The PT is used to monitor the therapeutic ranges of anticoagulants such as warfarin, also called Coumadin, and these therapeutic values are 1.5 to 2.5 times normal. International Normalized Ratio. The International Normalized Ratio, called INR, was established by the World Health Organization to standardize the INR results regardless of the reagents or methods used to analyze the blood. The INR is used to monitor the effectiveness of anticoagulant therapy such as warfarin, called Coumadin, that is given to inhibit the formation of blood clots. Normal values vary depending on the patient's disorder. For example, 1.5 to 2.0 is preferred for prophylaxis for deep vein thrombosis. 2.0 to 3.0 when treating deep vein thrombosis, and 3.0 to 4.0 when treating atrial fibrillation. So again, 1.5 to 2.0 is prophylactic, meaning preventative deep vein thrombosis level. The INR at 2.0 to 3.0 is desired when treating the deep vein thrombosis, and 3.0 to 4.0 when treating atrial fibrillation. Partial thromboplastin time. Partial thromboplastin time, PTT, measures the intrinsic system and common pathways of clot formation, which includes factors 1, which is fibrinogen, 2, which is prothrombin, 5, 8, 9, 10, 11, and 12. Factors 2, 7, 9, and 10 are vitamin K dependent factors. When there are reduced amounts of these clotting factors, the PTT is prolonged, meaning more time is needed for blood to clot. Like the PT values, the PTT results are reported in seconds along with a control value. The patient's normal value should be approximately equal to the control. A normal finding for the PTT is 60 to 70 seconds. Activators were added to PTT reagents to shorten normal clotting time and provide a narrow normal range. This shortened time is called activated PTT or APTT with a normal value of 30 to 40 seconds. The PTT is used to monitor the therapeutic ranges of patients taking anticoagulants such as heparin, and these therapeutic values are 1.5 to 2.5 times normal. Fibrinogen, or clotting factor 1, is part of the common pathway in the coagulation system. It is converted to fibrin by the action of thrombin during the coagulation process. Reduced fibrinogen levels occur in patients with liver disease, malnutrition states, and consumptive coagulopathies such as disseminated intravascular coagulation, abbreviated DIC. Normal values for adults range from 200 to 400 milligrams per DL, and those for newborns range from 125 to 300 milligrams per DL. Platelet count. Platelet count is the number of platelets, also called thrombocytes if you remember, per cubic millimeter of blood. This test is performed on patients with suspected bleeding disorders or clotting disorders. Normal values are as follows. Adults and children, 150,000 to 400,000 per millimeter to the third. Premature infants, 100,000 to 300,000 per millimeter to the third. Newborns, 150,000 to 300,000 per millimeter to the third. And infants, 200,000 to 475,000 per millimeter to the third. D-dimer. The D-dimer test assessed the activity of both thrombin used to form blood clots and plasmin used to break down blood clots. While plasmin breaks down the fibrin clots, fibrin degradation products and D-dimer are produced. The D-dimer assay provides a highly specific measurement of the amount of fibrin degradation that occurs as the clot is dissolved. Plasma normally does not have detectable amounts of fragment D-dimer. This test is used to confirm a diagnosis of DIC, which is abnormal. Electrolyte count, hemoglobin, and hematocrit. These measures are used to diagnose the presence of polycythemia and anemia. Patients with polycythemia have elevated levels of erythrocytes or red blood cells, RBCs, which increase the risk of clotting. Patients may develop anemia due to blood loss, which is indicated by RBC values, hemoglobin, and hematocrit values below normal. Bone marrow examination. An examination of the bone marrow may be done to assess for evidence of hyper or hypo production of platelets and red blood cells. This test may be indicated for polycythemia or thrombocytopenia. Radiological tests. 3 common radiograph tests to elevate vessels are useful in the diagnosis of individuals with clotting or bleeding tendencies. In all cases, the test produces an image of the vessel. Non-invasive venous studies. Ultrasound is used as a non-invasive approach for evaluation of venous thrombosis. Arteriograms allow visualization of arteries by injecting radio-opaque contrast into them so that the location and extent of occlusion or dilation can be identified. Venograms. Venograms of the lower extremities allow visualization of veins by injecting radio-opaque contrast into them so that the location and extent of thrombi can be identified. Clinical management. Clinical management related to clotting includes health promotion and the management of emerging or present conditions that compromise clotting. The ultimate goal is to optimize the clotting process. The Healthy People 2020 objectives for bleeding and clotting are summarized in box 20-1 in your book on page 194 in Concepts. Primary prevention. Primary prevention includes measures to promote health and prevent disease. For problems associated with excessive bleeding, the only true primary prevention measure is genetic counseling. Genetic counseling is advised for couples who have a history of bleeding disorders and want to start a family. Genetic counseling will assist couples to comprehend the medical facts, understand the risks and options, and make an informed decision. Measures to prevent bleeding as a complication of a disease process or medical treatments for other conditions are discussed in the collaborative care section. For this concept, most primary prevention measures relate to prevention of blood clots. Strategies for prevention include minimizing the risk for blood stasis, increased blood viscosity, and vessel injury. Patients at risk for venous stasis or those with clotting disorders are encouraged to enhance blood flow by performing leg exercises, engaging in regular walking, or wearing compression stockings. High-risk patients, those following knee or hip replacement surgery, are given anticoagulant therapy as a prophylactic measure. These agents are discussed further later. Women with an increased risk for clots may be advised to avoid taking birth control pills because of their adverse effect on clotting. Teaching patients about the importance of smoking cessation or stopping is a priority because nicotine both causes vasoconstriction, which contributes to stasis of blood flow, and damages the endothelium, contributing to atherosclerosis. Maintaining adequate hydration reduces the potential for increased blood viscosity, which is thickness. Secondary prevention is called screening. Secondary prevention includes screening, early diagnosis, and prompt treatment of existing health problems. There are no routine screening tests indicated for the general public related to this concept. Collaborative interventions for bleeding disorders. Prevention and control of bleeding. Prevention and control of bleeding are the cornerstones for management of individuals with bleeding disorders. Patients must learn to recognize the signs and symptoms of bleeding and to notify the healthcare provider when indications of bleeding occurs. They must also be taught strategies to minimize the risk for trauma. Patients with bleeding disorders or individuals who are taking anticoagulants are taught to avoid taking drugs that contribute to bleeding, such as any drugs containing aspirin. They are encouraged to avoid situations that could cause injury resulting in bleeding, such as participation in contact sports. Nurses may teach strategies designed to avoid bleeding. For example, nurses learn to use a soft bristle toothbrush to avoid bleeding from gums while brushing teeth. They use an electric razor rather than a blade razor to avoid nicks to the skin. Patients are encouraged to avoid blowing their nose forcefully to reduce the likelihood of nosebleeds. They should avoid getting tattoos and body piercings. Women who are menstruating should count the number of pads or tampons they use daily and notify the healthcare provider if that number increases. Patients should understand the importance of notifying healthcare personnel before seemingly benign invasive procedures such as teeth cleaning, manicures, or pedicures. Medications given by injection should be avoided if possible to prevent a needle stick that causes bleeding. When an injection is unavoidable, nurses use the smallest size needle possible. In addition, nurses monitor lab tests such as INR to assess risk and to provide direction in medication management. Management of bleeding episodes. During episodes of active bleeding, the obvious goal is to control the hemorrhage. Direct pressure over bleeding sites is indicated. The use of topical agents such as gel foam or fibrin foam may also help to slow the bleeding. Ice packs are also indicated for topical bleeding or bleeding within a joint space. Pharmacologic agents and the provision of supportive care, such as volume replacement and oxygen support, may be needed to prevent the progression of bleeding to the point of hemodynamic instability. Pharmacotherapy, clotting factor replacement or stimulating agents. Several agents are used to replace factor VIII and factor IX, the deficient clotting factors associated with hemophilia. Desmopressin acetate is a synthetic vasopressin agent that stimulates the release of factor VIII and von Willebrand factor. This agent is useful for milder forms of hemophilia. Platelet replacement agents. Several pharmacologic agents are used to increase the number of platelets. Platelet growth factor agents such as oprelvecin, romaplastim, and eltrombopag stimulate bone marrow production of platelets. The first one is spelled OPRELVEKIN. The second agent was ROMIPLOSTIM and ELTROMBOPAG. These drugs stimulate bone marrow production of platelets. This is on page 194 in Concepts. A transfusion of platelets is also a way to increase a patient's platelet volume, but this is generally performed to treat life-threatening hemorrhage. Collaborative interventions for clotting disorders. Because there are several conditions that can lead to clotting, collaboration interventions are dependent on the underlying cause. Pharmacotherapy. Several groups of drugs are used to treat individuals with clotting disorders and to prevent the formation of clots among high-risk individuals. Anticoagulants. Two common anticoagulant agents used to prevent the formation of blood clots are warfarin and heparin. Warfarin's other name is Coumadin, acts by decreasing the production of 4 vitamin K dependent clotting factors, which is clotting factor 2, prothrombin, clotting factor 7, 9, and 10. Coumadin is the only oral anticoagulant currently available. People taking warfarin need periodic INR blood tests to determine the adequacy of the anticoagulant therapy and are taught to avoid foods high in vitamin K, such as spinach, that interfere with the action of the drug. Heparin acts by inactivating clotting factors, primarily thrombin and factor XA. Low molecular weight heparin drugs such as enoxaparin, which is Lovenox, and dalteparin, which is Fragmin, are the most commonly used agents in this category. 2 oral anticoagulants are available that do not require blood tests or restrict diet. One is dabigatran, which is Pradaxa, which acts by inhibiting thrombin and preventing platelet aggregation and thrombus formation by preventing the conversion of fibrinogen to fibrin. Another anticoagulant is rivaroxaban, which is Xarelto, which acts by inhibiting coagulation factor XA. Antiplatelets. Agents such as aspirin or clopidogrel, which is Plavix, acts as antiplatelets by preventing platelet aggregation. Direct thrombin inhibitors. These synthetic agents act as anticoagulants by directly inhibiting thrombin. An example of a drug in this category is bivaleriduin, which is called Angiomax, ANGIOMAX. Thrombolytic agents such as streptokinase, which is called Streptase, alteplase, which is a tissue plasminogen activator, and tenecteplase, which is TNKase, abbreviated, are used to dissolve blood clots. These agents act by digesting fibrin in clots and breaking down plasmin and other clotting factors. All of these agents have risks of serious bleeding. Invasive procedures for clotting problems. Phlebotomy is the removal of blood, a common treatment to prevent clots for individuals with polycythemia. The goal of this treatment is to reduce blood volume, blood viscosity, and bone marrow activity. Phlebotomy may be needed as often as every 2 or 3 months. Thrombectomy is the removal of a thrombus from a vessel. This can be accomplished through a catheter placed percutaneously or as an open surgical procedure, such as a direct arteriotomy arteriotomy or venous thrombectomy, in which the vessel is opened to remove the thrombus. Filters devices are used to prevent pulmonary embolism for individuals with clotting disorders who are unable to take anticoagulants or have a history of pulmonary emboli. Filters, also known as vena cava interruption devices, are inserted percutaneously through the right femoral vein or right internal veins and floated into the vena cava, where they block blood clots from reaching the pulmonary capillaries. Nutrition. Warfarin or Coumadin is an anticoagulant that acts by interfering with vitamin K-dependent clotting factors such as 7, 9, 10, and 2, which is prothrombin. The dosage of this drug is readjusted regularly to maintain the INR between 2 and 3. Patients taking warfarin should keep their vitamin K intake consistent to maintain the therapeutic effects of the drug. If the dietary intake of vitamin K increases, then the dose of warfarin must be increased as well, and vice versa. Sources of vitamin K include green leafy vegetables such as spinach or kale, mayonnaise, canola oil, and soybean oil. Positioning. Positioning affects blood flow and comfort. Patients with a deep venous thrombosis, a DVT, also known as a venous thromboembolism, in the lower extremity are taught to elevate the affected leg when lying or sitting to facilitate venous return to the heart. By contrast, patients with an arterial thrombus of a lower extremity are taught to position the affected leg in a dependent position to use gravity to improve perfusion to the feet. During the acute phase after a brain attack, patients are positioned with the head of the bed elevated at least 30 degrees to facilitate venous blood flow from the brain to help prevent cerebral edema. Positioning for all patients prescribed bed rest includes preventing pressure ulcers by repositioning them as needed to maintain perfusion in dependent areas. Bed rest patients wear sequential compression devices to stimulate venous return to the heart. Again, reviewing collaborative interventions for clotting disorders. Control of bleeding, direct pressure on the site if possible, ice application, topical agents such as gel foam or fibrin foam, blood volume replacements, critical care management if hemorrhage leads to shock, pharmacological agents such as clotting factors replacement of clotting factor 8 and 9, and a drug called desmopressin, and platelet replacement, platelet growth factor agents as well. Interrelated concepts. Perhaps the closest interrelated concept is perfusion. Perfusion of blood through blood vessels is impaired when blood clots slow or stop blood flow. In addition, uncontrolled bleeding and hemorrhage can lead to excessive blood loss. Excessive blood loss threatens adequate volume of blood needed to perfuse oxygenated blood to all body tissues. Clotting is also interrelated with gas exchange because inadequate perfusion is linked to inadequate gas exchange in the peripheral tissues. Also, gas exchange is impaired when pulmonary emboli reduce pulmonary capillary blood available to carry oxygen from alveoli to cells. Because the brain is highly dependent on the steady perfusion of oxygenated blood, intracranial regulation is also interrelated with clotting. Interruption of cerebral blood flow, either due to cerebral blood clots or due to cerebral hemorrhage, can lead to brain tissue injury or death. Examples of such problems include stroke, aneurysm, traumatic brain injury, and communicating hydrocephalus. Individuals with clotting disorders can experience impaired mobility due to illness or recovery from surgery. This immobility increases the risk for DVT. Treatment for DVT is bed rest, which further impairs mobility. Pain is a common symptom experienced by patients from an arterial thrombus or constriction, impairing perfusion to a lower extremity, as well as by hemorrhage in a joint space. Individuals with venous clots also experience pain. Another closely related concept is patient education. This concept links to clotting as a way to enhance primary prevention strategies, as well as to help patients manage their bleeding or clotting disorders. Individuals with clotting disorders require extensive patient education. Also, inadequate education can lead to complications. Question. A condition manifested by a reduction in the number of platelets is called leukocytopenia, thrombocytopenia, erythrocytopenia, or polycythemia. Your answer should be thrombocytopenia. What is the normal value for adults and children of the number of platelets in the blood? For adults and children, it is 150,000 to 400,000 per millimeter to the third. That should be number 2, even though it's not exactly written correctly. What blood test can assess the activity of both thrombin and plasmin? Is it prothrombin time? Is it INR, International Normalized Ratio? Is it partial thromboplastin time? Or D-dimer? Again, this is the blood test that assesses the activity of thrombin and plasmin.